5, 4, 3, 2, 1. You are ready. You live.
Good evening, everybody. Welcome to today's webinar, organized by the Psychodermatology Association of India, on the topic of adverse drug reactions to psychotropic drugs. To start off the event, I would like to request our president, Dr. Om Prakash Singh sir, to present his presidential address.
Good evening, everyone. First of all, let me apologize for not being present. Since I'm traveling after our annual conference, this is our second webinar, and I must thank our secretary, Dr. Avinita, and CME chairperson, Dr. Narang, for this wonderful presentation, which is about the psychotropic adverse reactions, particularly dermatologicals, which are very important to know for psychiatrists and dermatologists both. I also thank our today's moderator, Dr. Smita Prabhu, and our speakers, Dr. Sendil and Dr. Shubdeep Singh. And also welcome and thank our panelists, Dr. Latif, Dr. Rogesh Ji, and Dr. Chinmay Deshpande. I know that this will be wonderful, and this webinar will add knowledge to both the psychiatrist and dermatologist, and we will continue with our endeavors of expanding knowledge and sharing it. Thank you so much.
Thank you, sir. Now we would like to move on to the main event of the evening, in which Dr. M. Sandil Kumaran sir, Professor of Department of Dermatology, PDAI Chandigarh, would talk about the adverse drug reactions to psychotropic drugs. Sir, on to you.
Thank you very much. Can I have my presentation, please? Good evening, everybody. With the advent of this subgroup, such called as the psychodermatology, most of we dermatologists have been practicing a little bit of psychology also in treating our dermatology patients, basically because most of the dermatology problems are chronic, long-standing, and seriously affect the quality of life of the patient. And this topic is pertinent to both the psychiatrists as well as the dermatologists. At the outset, I would like to thank the team which is doing this presentation, as well as Dr. Tarun, and give me an opportunity and give me a talk on this pertinent topic, that is cutaneous adverse drug reaction to the psychotropic drugs. Can I have my next slide, please? So early studies on the incidence of dermatologic adverse drug reactions with psychotropic drugs have estimated to be around 5%. And the cutaneous reaction to these drugs are seen in all cases of psychotropic medications, including antipsychotics, antidepressants, anxiolytics, and miscellaneous agents. And there are studies which have shown that people who are taking 2 or more psychotropic medications are more prone to have this cutaneous adverse drug reactions compared to those who are on monotherapy alone. And this reaction usually develops within initial starting the treatment itself. Next slide. The commonest morphology of the drug reaction which is seen in the psychotropic drugs are the exanthematous type of reactions, and one of the which studied a long more number of inpatients, psychiatric inpatients, that is around 15,438 medical inpatients in Boston, showed that 347 patients had around 358 cutaneous reactions, and the patients were diagnosed by dermatologists to having the secondary skin eruption or skin reaction, and the morphology they noted include morbilliform, maculopapular, and exanthematous skin eruptions with a rapid onset and widespread effect of hives and generalized itching. And they showed that the drugs used in the treatment of bipolar disorders had the highest reported prevalence of cutaneous adverse effects. Next slide. So as I said, this was another study by Lang et al. They showed that they also showed that the exanthematous type of reactions is the more common kind recorded severe cutaneous adverse drug reactions, and the most common symptom was pruritus in 50% of the affected patients, followed by edema in 12%, and the median clinical latency between the intake of the drug and the onset of reaction was 10 days in all subtypes, and life-threatening cutaneous adverse drug reaction, that is CADRs, amounted to only 3% to 3% of the CADR, whole CADR in total, and immediate drug discontinuation was the direct measure in the vast majority of the cases taken by the authors, and they found improvement in most of the patient, and drug treatment for the cause CADR included antihistamine in around 50% of the patient, followed by steroids in this study group. Next. So, with this brief background, the adverse drug reaction to the drugs have been classified broadly in literature into two types. One is type A and type B. Type A is one which is shows what we know as the presenting adverse reaction of the drug per se. That is, represent the predictable reactions such as the anticholinergic or the antipyramidal signs of the given antipsychotic drug. The type B is one which represents the idiosyncratic reactions such as adverse cutaneous drug reactions, and the latter of which has been underreported due to the fact that most of these are benign and easily manageable. Next slide. So, this table summarizes the cutaneous reaction relevant to psychiatry. So they have all the how the disease person presents to us in the OPD, as well as the definitions for it. So an urticaria usually presents as pruritic edematous wheals which occupy the superficial dermis, and the deep dermis, when it's involved, it is called as the angioedema. So urticaria and angioedema can be present in a given patient. Next is an exanthematous eruption, wherein we have raised red macules or papules that may be associated with fever and moderate to severe pruritus. The eruption usually begins on the trunk or the areas of the pressure. Palms and soles can also be involved. The third type of reaction commonly seen are the photosensitivity reactions, which can be phototoxic or photoallergic. That I will try to show you when the presentation goes on. The one of the rare type of presentation side effects CADRs are pigmentary changes, which were commonly seen when chlorpromazine was used, especially on the sun exposed body areas. Uh, Let me go back to the same table, please. And then bullous eruptions, which included erythema multiforme, Steven-Johnson syndrome. And other rare causes of cutaneous reactions were alopecia, verrucous growth, psoriasis, folliculitis, contact dermatitis. The first four is primarily caused by one single antipsychotic drug, that is lithium, most of us know in dermatology, and the others are contact dermatitis and serum sickness-like reaction. Next, yeah. Next slide. And this table shows the most significant cutaneous side effects and the given psychotropic medication. If we are finding a patient of urticaria, look to see whether the patient is having lithium, trazodone, or fluoxetine. If it is an exanthematous rash, this commonly, as I said, commonest one, see if the patient is taking carbamazepine, mepryptylin, lithium, trazodone, decimiprin, fluoxetine, alprazolam, bupropion, nefazodone, risperidone, etc. This is for the psychiatrist. They'll be able to diagnose the patient as early as possible. Then the photosensitive reaction, all antipsychotics can cause, including chlorpromazine and thyroidazine. Pigmentation changes are common with chlorpromazine, thyroidazine, haloperidol, clozapine, perfenazine, diazepam, and after dermabrasion. This was one thing where, which is very, very rare, especially for a diazepam to cause a pigmentary side effect. And bullous reaction, risperidone is the commonest cause. Diazepam overdose, especially AEM, where when there is a combination of drugs with lithium and trazodone concurrently with fluoxetine, sertraline, and carbamazepine, is the most common culprit to cause this sort of bullous reaction. And Steven-Johnson, of course, carbamazepine. Next slide. So others, as I said, alopecia, verrucous growth, psoriasis, and folliculitis, lithium is the common culprit. And when you're thinking of contact dermatitis, the common culprit antipsychotics are thyroidazine, haloperidol, flufenazine. And serum sickness-like reaction can be got with fluoxetine, and injection site reaction can be got with haloperidol. Next slide. Next slide, please. So this is the common class of drugs which we write. The dermatologist, most of the time we fail to see what is the class. We generally write the name of the drugs per se. So just summarize so that we rush through it. We have the tricyclic antidepressant. The common drugs we write are amitriptyline and chlorimiprine and imipramine. The monoamine oxidase inhibitors, phenylazine. This we hardly write it in dermatology practice. SSRIs is another common drugs which we prescribe: fluoxetine, citalopram, acetylene, paroxetine. Then NARIs are, that is, which increases the noradrenaline level. This we don't try it in dermatology. The psychiatrists probably write it more. The SNRIs are venlafaxine and duloxetine. NASSA, that is noradrenaline and specific serotonin antagonist. That is the, we have the mirtazapine and meancerin. Next slide. Then we have the typical antipsychotics and atypical antipsychotics, which are chlorpromazine and olanzapine and etc. Mood stabilizers: lithium, sodium valproate, carbamazepine, and lamotrigine. These are the few class of drugs which you commonly write. Next slide. So this group shows the examples of the psychodermatological conditions for which the psychotropic medications may be used. So antipsychotic medications are commonly used in primary psychotic disorders. The SSRIs you commonly prescribed in body dysmorphic disorder. Antidepressants in neurotic excoriations. Antidepressants again we prescribe in trichotillomania also, and lipid soluble psychotropic medications like chlorpromazine, imipramine, fluoxetine, etc. we write in dermatology conditions with psychosomatic features. Next slide. So this is the criteria which was given by Groman et al. As a causality criteria when to suspect a given drug is the common culprit drug which causes the CADR. So it can be classified into four subdivisions, that is possible, probable, definite, and questionable. Possible is when the ADR is unknown or we have an alternate explanation which is more likely for the given reaction. Probable is when the ADR is known for the drug in question and the time, course, and dosage in accordance with the previous experience of the given treating consultant, or we have alternative explanation is very less likely here. Definitive is when we are able to prove that the given drug is the culprit drug by a re-challenge, and questionable is questionable, and we, as there is no sufficient documentation whether this drug is the one common cause for the adverse drug reaction. Next slide. So coming to the, I thought rather than telling about the pathogenesis of how the drug reaction occurs, I thought I'll show the morphological patterns which will be helpful for our psychiatric colleagues to catch the reaction, cutaneous adverse drug reaction, as early as possible and refer to us immediately. So the commonest rash which we get because of psychotropic drugs, the exanthematous rashes, which usually present within the first 3 to 14 days of starting the drug. It could be macular or maculopapular erythematous skin lesions. It can also have mucosal lesions, especially when the severity of rash increases, and patient can also have a sore throat. All antidepressant, all antipsychotics, and all anticonvulsant can present with this sort of CADR. It can mimic measles, scarlet fever, etc., and may represent an early stage of severe life-threatening drug reaction like SGS, because if the patient is not caught at this earlier stage of maculopapular rash, the patient can progress on to the more severe scar, that is cutaneous, severe cutaneous adverse drug reaction like Stevens-Johnson syndrome. Next slide. So this is how erythematous maculopapular rash can be, with a diffuse spreading erythema with macules and papules can be there in the first picture. The second picture shows a more predominant papular pattern. Next slide. When the reaction is too high, we can have tiny pustules also present along with this maculopapular rash, which is exfoliating in the third picture. And the fourth one, we have the diffuse macular rash can be seen. Next slide. Urticaria, it is the second most common presenting type of cutaneous adverse drug reaction. It can present within minutes to hours of starting the drug. Sometimes it can be late. The wheals, which has a pale center and a red borders with migratory pattern characterized by changing in shape and location, and can occur with or without angioedema, as I initially said. And herein also, all antipsychotic drugs, that is antidepressants, antipsychotics, and anticonvulsant can present with urticaria. It can be either immune mediated, especially complement mediated urticaria, and can also lead to laryngeal angioedema and anaphylaxis in a few. Next slide. Coming to erythema multiforme is a hypersensitive reaction most often presents as an acute eruption of papules, plaques, and blisters on the limbs, soles of the feet, and palms and soles. It is accompanied by an elevated temperature and a generalized feeling of malaise, and mucosal involvement occurs in erythema multiforme major only. And although it can be usually due to viral infection, but drugs are the common culprits also. Psychotropic drugs that can cause erythema multiforme include bupropion, clozapine, and fluoxetine. Next slide. So these are how the erythema multiforme looks like. It can have three zones, that is a central necrotic zone followed by an edematous zone and then the third zone of flare. So these are the thing. This is the eryem which is caused by an anticonvulsant, the typical target type of lesions. Next slide. Cutaneous vasculitis, it presents with palpable purpura or urticaria eruptions. It's usually rare. Cutaneous vasculitis is usually a rare type of CADR, and in some cases there can be evidence of systemic vasculitis also. The psychotropic medications that can cause vasculitis include oxcarbazepine, methylphenidate, and chlorimipramine. Next slide. So this is how we have from small vessel vasculitis, that is palpable erythematous palpable purpuric lesion, which can be present in the lower limbs, to a large necrotic ulceration lesion can also be found. The third picture shows a case of urticarial vasculitis wherein the urticarial lesions is persistent for more than 48 hours. There is no associated itching, but burning sensation will be there in case of urticarial vasculitis. Next slide. Erythema nodosum is another inflammatory disorder presenting with painful red indurated plaques, usually on the lower limbs. And drugs that may cause EN include fluoxetine, paroxetine, and venlafaxine. Next slide. So this is how an erythema nodosum will look like. They are deeply placed, tender erythematous nodules. Here we can see on the calf as well as on the shin and above the medial malleolus. So tender erythematous plaques are known. Next slide. Coming to the other one, that is fixed drug eruption, which can occur within few hours to 24 hours, especially if the patient has re-ingested the suspected drug. And it usually presents as round or oval edematous plaques of varying sizes affecting any part of the skin or mucous membranes, usually preceded or accompanied by itching. Bullae may exist in severe cases and dusky brown macules after the eruption fades out. It can occur with any drug, including antidepressant, antipsychotics, and anticonvulsants. Some of the other drugs which can cause FD are given below, and the exact mechanism but how it happens is unknown. Next slide. This is the characteristic how the FD look like. That is the necrotic in the purpuric patch in the center with the necrotic bullae with surrounding erythematous flare. Next slide. Pigmentation, it is a rare type of CADR. It has been reported. I think when I was looking into the literature, while I was trying to read about the pigmentation as a psychotropic drugs as the cause for the pigmentation, there were very, discordant reports as far as chlorpromazine as a causative agent for pigmentation was found. Initial reports said the hyperpigmentation because of the drug was dose dependent. But subsequent large-scale studies as well as systemic analysis showed that the pigmentation because of chlorpromazine is not dependent on dose or the duration per se. So it has been reported with long, term use. This is I've written as majority of studies show this, and pigmentation may involve the skin as well as the eyes. That is, involving the pigment can be seen on the retina, lens, and the cornea. Nails and teeth pigmentation may occur with certain medication. So the common culprits here are low potency antipsychotics like chlorpromazine and thioridazine, and TCA antidepressants, all SSRI, venlafaxine can cause hyperpigmentation compared to the hyperpigmentation of that of chlorpromazine and anticonvulsant. Next slide. This was a case report of chlorpromazine induced severe skin pigmentation and corneal opacity in a patient with schizophrenia, which was published in International Journal of Dermatology long time back. Next slide. See the bluish gray type of deposits which can be seen on the face commonly, very minimally on the cornea over here, more on the exposed part of the face, and even the eyelids are also affected in this case. Next slide. Photosensitivity. The skin reaction may begin soon after the systemic chromophore reaches the skin, that is the culprit drug and the combination. And cutaneous can present either as a phototoxic, that is, we have an exaggerated sunburn type of pattern in a sun exposed skin, or a photoallergic reaction, that is, which becomes more generalized skin eruption. Okay, this is how to generally differentiate between a phototoxic and a photoallergic type of drug reaction. And here the causative is all antipsychotics, particularly chlorpromazine is the common culprit over here. These are the other drugs which can cause the photosensitivity, sulfonamides and sulfonylureas, etc. And whenever we are prescribing these antipsychotics which can cause photosensitivity, patients should be advised to use proper sunscreen and minimize their sun exposure. Next. Alopecia may occur rapidly or a few months after starting the drug. The hair loss usually requires 2 to 18 months after stopping the drug discontinuation, and the common cause, the antipsychotics which can cause alopecia are lithium, valproic acid, and less frequently occurs with other mood stabilizers, mostly antidepressants and antipsychotics. Next slide. So this is the depending, the highest one which can cause alopecia is valproate, and the least one being phenytoin. Next. So other cutaneous reaction which can be found with antipsychotics are very rare ones, like drug reaction can be found with antipsychotics. The morbidly formed drug eruption, also the drug induced diffuse alopecia. These are some of the very rare CADRs. Next slide. Now coming to the risk factors which can cause this sort of CADR, which include, which is there in the literature, are a person of African ancestry. Females are more prone to get CADR. One who's aged greater than 70 years, and if there is a personal or a family history of cutaneous adverse drug reaction. Next one. Now, how this risk can be reduced? That is, once we are dealing with this patient, we should do a careful assessment of the individual prior to prescribing a new medication, including their proper medical history, past history of any drug reaction if the patient had, and a family history of drug reactions. Sun protection needs to be given when you are dealing with the photosensitive medications. Next slide. So coming to the scars, that is a severe cutaneous adverse drug reaction, we have three presentations over here. One is the AGEP, that is acute generalized exanthematous pustulosis. Then you have the DRESS syndrome, that is drug reaction with eosinophilia and systemic symptoms, and Stevens-Johnson syndrome and toxic epidermolysis. Next slide. So this is I already, I think here, erythema multiforme. The common causative drug over here are the anti-epileptics, the carbamazepine, valproic acid, lamotrigine, gabapentin, etc. And Stevens-Johnson syndrome is same as EMA, erythema multiforme. Next slide. For 10, it's also the same. For DRESS syndrome, almost exclusively occurs with the anticonvulsants, that is phenytoin as well as carbamazepine, if you give me. Exfoliative dermatitis, that is erythroderma. Most common culprits here are tricyclic antidepressants and other antidepressants, antipsychotics, including lithium and mood stabilizers, sedatives, and hypnotics can also cause exfoliative dermatitis. And drug hypersensitive vasculitis can be caused by clozapine, maprotilin, trazodone, carbamazepine, lithium, phenobarbital, diazepam, and chlorodiazepoxide. Next slide. So this I've just put depending upon the time of onset, that is the patient takes a drug, and when does the patient will present with this sort of a scar. AGEP, that is acquired generalized exanthematous pustulosis, usually presents earlier in the period, that is within 1 to 2 weeks of starting the drug itself. Stephen Johnson's and 10, usually between 2 weeks to 4 weeks. This is the gap we have. That is a short. These two are the short latency. One which has a long latent period is that because of that is drug reaction, eosinophilia, and systemic symptoms. Next slide. So diagnostic approach for this, in all these phenotypes, drugs are implicated mainly in the pathogenesis and identification of the causal drug, and stopping it remains the main modality of treatment. A proper history taking is very important, and drug causality algorithm, especially when we deal with a drug rash, the drug causality algorithm must be put. That is, when the patient presented to the doctor, or what are the different in the past history, how they have taken the drugs from this day of starting of drug till when the patient presents you in the OPD, will be helpful in identifying the culprit drug. Now, the gone are those days where patients used to get one drug or two drug and land up with you in the OPD. Nowadays, patient who present you with drug reaction are on multiples of drugs because of other comorbidities also. So one of the studies which recently published showed that an average patient will have at least 8 drugs when he's presenting to you in the OPD. So in that case, one thing which can help are the Alden's algorithm as well as Naranjo's algorithm, which can help you scale, which can help you diagnosing the coming to a not too very very appropriate, but very closer to the culprit drug as possible. So Alden is the widely used in Steven Johnson's and tend to find out the culprit drug, and other algorithm also used for drug causality assessment, but nothing is gold standard. Next slide. Next slide. No, this one. So whatever we have is this is the two things which I was talking. That is the Alden score and the Naranjo's algorithm, which are commonly used. Alden's is the very user friendly, and it's easy for us to find the culprit. I think the most common drug among the group of drugs which the patient is taking as the culprit drug, which can cause Steven Johnson's or TEN. Next slide. So Steven Johnson syndrome are more severe mucocutaneous reactions commonly triggered by medications characterized by extensive necrosis of skin and detachment of the epidermis. Mucosa is involved in greater than 90% of the cases, and estimated incidence of these is up to 2 to 7 cases per million per year in the world population, and overall mortality rate among these patients is approximately 30%, ranging from 10 to percent for Steven Johnson and up to 50% in TN. Mortality continues to increase up to 1 year after the disease onset. Next slide. So this is the clinical image of how the thing necrotic blisters with atypical targetoid type of lesions, which can be present, which can be seen in the first picture, or diffuse peeling of sheets of skin, as a second picture shows of TN. The mucosal involvement, which can be drastic and cause lot of sequelae in form of hemorrhagic cheilitis, as well as the involvement of the conjunctival mucosa. Next slide. So the most common cause of SHTN is the medication, and the latency period of 2 to 4 weeks, 2 to 3 weeks, what I said, that is 7 to 10 days, but it can also be between 5 to 28 days. Most common psychotropic drugs implicated are alprazolam, duloxetine, carbamazepine, lamotrigine, phenobarbital, and sertraline. Next one. So this is the severity model assessment. There are two models to assess how severe the SGSTN is there. One is the score 10 model, another one is the ABCD10 model. This is the latest, which is published in 2022, and they claim that the ABCD model is a better model to predict the mortality in Steven Johnson's and 10 in resource poor settings. This is available on the net, and people when dealing with this Steven Johnson, this has to be calculated at day 1 as well as day 3. That will tell what is the progressive nature of the Steven Johnson syndrome is. Next slide. It help the predicted mortality rate. So ABCD10 is calculated on day 1 and 3 of admission to predict mortality. Various studies have shown that this ABCD10 has acceptable overall performance, but revealed mortality underestimation and was inferior to performance of Scoten in one of the studies, and inconsistent with Scoten. ABCD10 was a better model in another study. Next slide. So management of SGSTN, we all know the patients with a BSA detachment greater than 10%, rapid progression or suspected organ dysfunction should be treated as in a burn care unit, and patient must be kept in a side room or reverse isolation room controlled for humidity, or a pressure relieving mattress with the ambient temperature between 25 degrees to 28 degrees. Causative drugs should be stopped immediately, and a multidisciplinary care is recommended. Next slide. Coming to drug reaction, eosinophil and systemic symptoms. I will not go much details into it because Dr. Sukhdeep will be covering in his next talk when he is talking about a case of DRESS syndrome itself. Can you clip on the 2-3 slides, please? Next slide. Next. 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 Yes. Before this. So that one, the one more scar is AGEP, that is acute generalized erythematosus pustulosis. So the common drug which can cause, which is of importance for us today, is the carbamazepine. Next, usually comes within the latency period of 2 to 5 days. Next slide. Before this, no. Okay, there's another variant thing. Euroscar is the one. Believe this one. Euroscar. Euroscar criteria is one which is used for the diagnosis of AGEP and which can help the severity score. Also, it helps in showing how severe the patient is, which takes into consideration of morphology, the course of the disease, as well as the histological presentation. Next slide. Management. AGEP is a self-limiting disease. Once the offending drug has been stopped with a mortality of less than 2%. In case we have this AGEP-T and OLAP, one of the things which was flipped, that was one of the latest severe patient where we found probably there could be an overlap between an AGEP and TN, or a recalcitrant case of AGEP. Following systemic therapies can be used. Oral corticosteroids, cyclosporin, infliximab, and IVIG. I'm not going very detailed into the management because management of scar itself is a presentation of 1 hour to 2 hours. So I'll not go into deep into this. In decombating phase, plain emollients is advised and prophylactic systemic antibiotics should be avoided. Next slide. So management and prevention. First thing what we require is to monitor and have an idea about the different CADRs which can come up in a given drug when we are prescribing, so that we know how to identify the drug reaction at the earliest. So first one is monitoring and early recognition of the early recognition. Next, dose adjustment and medication modification. Third one is discontinuation of the culprit drug and from it withdrawal plans, that is to give other drugs which is non-cross reactive. Fourth one is give proper supportive care and symptomatic relief for the patient. And last one and the most important one is a multidisciplinary collaboration between the dermatologist and the psychiatrist. That is, the psychiatrist find something which is finicky with the patient as early as possible and refer to the dermatologist, so that the dermatologist trying to diagnose the reaction as early as possible. Next slide. So this was, I'll try to leave with this one study which was lately recently come, the cutaneous adverse drug reaction to psychotropic drugs and the risk factors. So here we can see the common age group which was affected in this study was more than 50 years, of close to 48 to 49 years of age. Females were common sex which was affected with a CADR with a, and note the mean number of medication, that is the patients were more than 3. So this is what I will try to highlight previously in my talk, that most of the patients who are having more number of psychotropics are common to have this sort of CADR compared to monotherapy alone. And polypharmacy was present in 282 of the patients, come out 282 out of 594. Next slide. So the antipsychotics were prescribed for mental and behavioral disorders due to psychoactive substance use, schizophrenia, schizotol, delusional disorders, mood disorders. Next slide. So these are all the different drugs which are classes which is used, right, from TCAs, SSRIs, SNRIs, etc. And see the number of cases they have been prescribed. The common being antidepressants in 411 patients. Next slide. So the cases and the non-cases per relevant single drug, that is the cases where chloromiprin caused a reaction in 19% of the people, trimipramine in 24, carbamazepine in maximum, that is the anti-epileptic is the common thing, in 149 patients, and chlormethazole in 24 patients. Next slide. So with this brief background and a fast talk which was given for half an hour, so I was able to probably give only a gist of notes, whatever I can give you, because we can talk about close to an hour or 2 hours on what are the different adverse drug reactions are there and bore you on this very Sunday evening. So I didn't want to do that. I just wanted to touch you on the different morphological presentation which can get in case of a cutaneous adverse reaction secondary to antipsychotic drugs. So my take-home message is psychotropic drugs are frequently used in both by psychiatrists as well as general medical practice as well as dermatologists nowadays. And being familiar with the common side effects and their management may assist the psychiatrists and the dermatologists in selection of the agents to suit individual patient needs. And although most dermatology reaction to drugs follow a benign course after drug discontinuation, the serious side effects, that is the scars, what we say, that is the AGEP, the Steven Johnson syndrome, and the DRESS syndrome needs to be borne in mind so that the patient can be caught at the very early stage in the disease process and try to improve them, treat them adequately, stop the culprit drug, and give proper treatment so that the patient is saved. Next slide. I acknowledge Dr. Apurva who helped me in making the slides. Next slide. Thank you very much.
Thank you very much, sir. That was quite an elaborate and exhaustive compilation of all the information that we might require to understand the cutaneous adverse drug reactions due to psychotropic drugs. Now, to move on, we would like to have a case presentation followed by a case-based panel discussion. For the case presentation, I invite Dr. Sukhdeep Sim, the Senior Resident of Dermatology at PDAI Chandigarh.
Good evening, everyone. Am I audible?
Yes, Sukhdeep.
So I'll be presenting a case of DRESS after psychotropic drugs. So psychotropic agents such as mood stabilizing drugs, antidepressants and anti-anxiety drugs are in widespread use, and skin reactions caused by these are twice as frequent as those by most other drugs. And DRESS is a specific severe idiosyncratic reaction causing skin, liver and hematological disturbances. So coming to the case, so we had a 51-year-old female who was a homemaker. She was admitted with us for 1 week with the chief complaints of fever for 15 days, facial swelling for 10 days, and red raised lesions over the body for 5 days. She was a known case of migraine for which she was given tablet amitriptyline 25 mg 1 month prior along with tablet paracetamol 500 mg once daily. 15 days later, she developed fever with chills and rigor. After that, she developed facial swelling and followed by erosions over the lips with yellowish brown crusting. And this was followed by appearance of red raised lesions over the body. There was also involvement of oral mucosa, palms, soles, and scalp. So these are the images on the abdomen and the limbs. There was no history of involvement of genital, ocular mucosa, or any raw areas of the skin. There was no history suggestive of systemic involvement, no yellowish discoloration, photosensitivity, recurrent oral ulcerations, recurrent fevers suggestive of connective tissue diseases. There was no history of cough, burning, micturition, and no history of decreased urine output or blood in urine or prothuria. She had regular bowel and bladder movements. However, her sleep was disturbed for 2 days and she had a normal appetite. There was no significant family history and she had attained her menopause 1 year back. On examination, uh, she had fever of 101 degree Fahrenheit. Along with that, she had pedal edema and facial edema and inguinal lymphadenopathy. The systemic examination was, however, within normal limits. The cutaneous examination revealed facial edema and erythema, and there were multiple pustules present, some discrete, some confluent, causing yellowish brown adherent crusting over the forehead and nose extending to the cheeks and upper lip. And erosions and yellowish brown crusting was present over the lips also. And there were few atypical targets and erythematous or purpuric macules over the neck with non-blanchable erythema. The trunk showed typical raised target lesions, flat atypical targets with central necrosis and surrounding non-blanchable erythema with purpuric macules coalescing at places to form erythematous plaques. And there were few discrete non-follicular pustules which were present. The examination of limbs revealed typical and atypical targets with central necrosis. And on the palms and soles, there were few discrete purpuric lesions and tender discrete papular and vesicular lesions were also seen. The investigations revealed eosinophilia of 12.9%, which progressively increased over the course of her admission. And the absolute eosinophil count was also 2,900. Her blood chemistry is revealed transaminitis of 85 units and 118, and her CRP was also raised. The peripheral smear showed normocytic RBCs with absolute eosinophilia, and there were no atypical lymphocytes. Rest of the investigations, including ECG, X-ray, and cultures, they were sterile, and the viral serologies were also negative for CMV, EBV, and ANA was also negative. Now, the histopathology showed subcorneal pustules with mixed inflammatory infiltrate, and dermis showed the presence of dilated dermal capillaries with perivascular mixed inflammatory infiltrate with lymphocytes, histiocytes, plasma cells, neutrophils, and eosinophils with endothelial swelling. And the features were suggestive of a drug-induced dermatitis. Based on these, we had kept differentials of DRESS, SJS10, erythema multiforme, and Rowell syndrome. However, after all the investigations, the final diagnosis was drug reaction with eosinophilia and systemic symptoms due to amitriptyline. The points in favor were there was initiation of drug 2 to 6 weeks prior to the onset of symptoms, a prodrome of fever and pruritus, characteristic polymorphic rash with facial edema, typical atypical targets, non-blanchable erythema, non-follicular pustules, and relative sparing of mucosae. An organ involvement was suggestive of liver involvement with elevated liver enzymes, and eosinophilia and lymphadenopathy were also present. So we did a registrar scoring system, and her scoring was 8, which was suggestive of definite DRESS. She had fever, eosinophilia more than 1.5, and there was involvement of more than 50% body surface area with skin rash was suggestive of DRESS. Biopsy was also suggestive of DRESS, and there was involvement of liver, and the resolution took more than 15 days. So she was treated with tablet prednisolone 50 mg once daily at a dose of 1 mg per kg per day, tablet doxepin because of severe sleep disturbances, tablet paracetamol, tablet levocetirizine, topical corticosteroid lotion, and coconut oil and mupirocin ointment over the face. So patient developed insomnia and severe sleep disturbances during the course of her illness. Sleep disturbances were non-responsive to standard treatment. So she was also given doxepin, and dose of prednisolone was kept higher at 60 mg for few days till some improvement was observed. She also developed mood swings with low mood, anxiety, and loss of self-confidence. There were feelings of hopelessness and helplessness. In between, the patient inadvertently self-tapered the steroids for 1 week, which led to recurrence of the cutaneous and these psychiatric symptoms. Therefore, slow tapering was advised over 2 months. And at 8 weeks, there was significant improvement in her both cutaneous and psychiatric symptoms. There was resolution of facial edema and the rash. And even the investigations, they were normalized by 2 months. So coming to discussion, so drug reaction with eosinophilia and systemic symptoms is a rare, potentially life-threatening adverse drug reaction with cutaneous manifestations, hematological and internal organ involvement. It is known by various names: anticonvulsant hypersensitivity syndrome, drug-induced hypersensitivity syndrome, and drug-induced delayed multi-organ hypersensitivity syndrome. So DRESS has a long latency period which ranges from 2 to 6 weeks, and severe hypersensitivity to medications and its active metabolites can occur. And there is role of genetic factors, immunosuppression accompanied with primary or reactivation of HHV6 infection predisposes the development of condition. So DRESS is commonly reported with anticonvulsants like phenytoin, carbamazepine, lamotrigine, but it has also been reported with other psychotropic medications, and they include clozapine. There have been reports of about 6 cases in a review published with the DRESS due to clozapine, with aripiprazole, lithium, ziprasidone, and even citalopram and fluoxetine. Recently implicated psychotropic drugs include benzodiazepines, even bupropion, mirtazapine, and amitriptyline. These are although rare but important to identify due to the associated severe course and mortality associated with DRESS. And amitriptyline administration has also been associated with skin rashes and hypersensitivity reactions such as urticaria, photosensitivity, as well as hyperpigmentation. So this was a report from our institution in which there was a case of DRESS which occurred in a young child after fluoxetine. Now coming on to antipsychotic induced DRESS. DRESS has been reported with a combination of olanzapine, sodium valproate, and also with chlorpromazine, and along with clozapine also. In these cases, although steroid administration is very well known to induce new or worsen pre-existing psychotic symptoms, psychiatrists should be aware that not all patients on steroids may experience psychosis, and life-threatening conditions like DRESS, they take the precedence in management. And one should be cautious about the worsening of psychotic symptoms in already diagnosed patients with psychosis. It might be beneficial to switch over to antipsychotic medications that are least likely to cause DRESS, or we can use alternative psychotropics like benzodiazepines for the time being. So this is a summary of the evaluation and management recommendations for psychotropic induced DRESS. So immediate withdrawal of the implicated drug through careful history taking is recommended, and by the use of various scores like Naranjo and Iden. And if indicated, hospitalization for fluid and electrolyte replacement, nutritional supplementation should be done. And the thorough lab evaluation should be done to assess internal organ involvement due to mortality associated. So we should get a complete blood count, urine protein, the chemistries, and the panel of viral serology should be done. And for organ involvement for hepatic, cardiac, pulmonary, renal, even endocrine abnormalities, they have been seen with DRESS. And if patients do not have these internal organ involvement, then we can just give supportive management. But if organ involvement is present, prednisolone is recommended. And if improvement is not seen with corticosteroids, we have other therapies also like IVIG, cyclosporin in cases of resistance. So we can use corticosteroids, which can be prednisolone or methylprednisolone pulses. IVIG can also be used, cyclophosphamide, cyclosporin, topical corticosteroids, and mycophenolate mofetil. So to conclude, DRESS is a severe cutaneous eruption that typically presents within 1 or 2 months of drug initiation, and common clinical features include maculopapular rash, elevated liver enzyme levels, lymphadenopathy, facial edema, and eosinophilia. And common psychotropic medications that have been implicated, apart from anticonvulsants, they include all these which I have discussed, and management of comorbid psychiatric illness includes strict avoidance of the implicated drug and other drugs of the same class. Like if there is a reaction to carbamazepine, we can use valproate in that case. Thank you.
Thank you, Dr. Singh. Now we would like to move on to a case-based panel discussion of the case presentation. For the case panel discussion, I would like to invite the moderator of the session, Dr. Smita Prabhu ma'am, additional professor of the Department of Dermatology at KMC Manipal. The panelists for the discussion include Dr. Abdul Latif EN, Professor of Dermatology and the Head of the Division of Psychodermatology at the Government Medical College, Calicut, Dr. M. Senthil Kumaran sir, Dr. Chinmay Deshpande, MD Psychiatry, a consultant psychiatrist at Youth Psychological Wellness Center in Pune, and Dr. Ragesh G as a lecturer from the IMHANS in Calicut, Kerala. Over to you, ma'am.
Thank you, Dr. Naveen. And I think Dr. Ragesh said he is not coming. So I welcome all panelists. I request Professor Dr. Abdul Latif, Professor Tarun Narang, Dr. Sukhdeep Singh, and Dr. Chinmay Deshpande to join me, please. Just give me a moment when I set up the screen show.
Tarunji? Yes.
Yeah, it's fine. So good evening, everyone. At the onset, my sincere thanks to PDAI officials, especially Dr. Abhinita and Dr. Tarun Narung for the invite here. And let me tell that I don't have much experience in treating with psychotropics because I have a very good psychodermatology setup in Manipal and I refer most of the cases to my psychiatric colleagues. So my job here is to ask questions to my esteemed panel members who have very good experience in treating, like Dr. Abdul Latif and Dr. Tarun Narang, the dermatologists. And of course, we have Dr. Chinmay Deshpande here. And I've heard that Dr. Sukhdeep Singh has his thesis on psychotropics and cutaneous adverse reactions. So welcome to all. And today my job is also made easier based on the previous two talks. So moving ahead, we have two main concerns here. One is cutaneous adverse reactions to psychotropics. And another main or equally important thing is the adverse drug reactions to psychotropics which we prescribe. Not necessarily cutaneous, but non-cutaneous. So let us move ahead. Have you ever encountered cutaneous adverse reactions to any psychotropic in your career so far, prescribed by others or by self? So can any of you take up? Dr. Latif, any instances that you remember?
Yeah, thank you, Dr. Smita. I think I'm audible now.
Yes.
Yes. And at the outset, let me thank the organizers for giving this opportunity and arranging this very good program. So I have seen few cases. One is a maculopapular rash, and the other one an SJS, Stevens-Johnson syndrome. And different drugs. One was, I think, for a risperidone, and the another one for an SSRI. So these two drugs I have observed the non-drug reactions. The drug reactions mainly, before mentioning, there are two types of drug reaction. One is a predictable and another one is unpredictable. So mainly we are focusing, I think, the unpredictable side effects. The other thing we know, if you're taking steroid, the patient will get acne. That is a predictable thing. But the idiosyncratic reactions that we can predict, that is the main problematic area in the drug reactions, actually. So these two types, one is an SJS, the other one a maculopapular rash I have seen.
Okay. So, Dr. Tarun?
Yes. Besides the SGSTN, initially we used to see a lot of SGSTN with carbamazepine and drug hypersensitivity syndrome, although not classically we may say that these are the psychotropic drugs which we use. We use more of SSRIs or other drugs. But of late, I'm struggling with a patient of mine who had bipolar disorder, who was on lithium, and he developed severe psoriasis. So I told my psychiatry friends to substitute lithium with some other drug which they prescribe for bipolar. He was started on valproate, but his bipolar worsened. So they had to shift back to lithium again. So his psoriasis became more severe. So that is what we are seeing in many of our patients, where you can't change lithium to some other drug which will help in their bipolar disorder. And sometimes we are at loss as to what to give to these patients who are already on a few psychotropic drugs, and we know there are many interactions between psychotropic drugs and the drugs, systemic drugs that we use in psoriasis. Unfortunately, biologics are not affordable by most of the people. So this is one case that I am struggling with at the moment. Besides this, we see a lot of alopecia due to valproate, or lightening of hair due to valproate. That is also common. Then maculopapular rash or urticaria because of SSRIs or antidepressants, that is again common. So these are the things that we see commonly.
Dr. Sukhdeep, have you anything to add on to this?
Sir, ma'am, apart from this, all of us have encountered acneiform eruptions after lithium, which are very common in practice, and they can be easily managed with the use of doxycycline. And apart from that, acute urticaria and even DRESS has also been encountered commonly in practice, but most commonly due to anticonvulsants like phenytoin, carbamazepine, I saw,
Yes.
and that's it.
So, Dr. Chinmay, in your practice, have you encountered any cutaneous reactions which has baffled you or which was unexpected? Can you give us
Yes,
your
ma'am.
experience?
At the outset, I would like to thank all the scientific committee members and all the seniors and colleagues for giving me a chance to participate in this this webinar. Yes, definitely. During my first year of residency, we had a patient of carbamazepine induced rash, and it was so severe. Like we didn't know how to manage that patient because he was a patient of bipolar disorder, and we couldn't even substitute any other drug, though we tried. I mean, me and our lecturers, but with the skin condition, I mean, worsening, it was a very difficult case to treat. But in the end, the rash subsided by efficient dermatological management by our Department of Dermatology, SKNMC. And also, I have seen severe rash develop with high dosages of SSRIs like fluoxetine, paroxetine, sertraline, and least I have seen with escitalopram, because escitalopram starting dose is 10 milligram and the highest dose is 20 milligram. So I've seen that rapidly increasing the doses or up titrating the doses of SSRIs can lead to severe rash, and then all the improvement we've had, we have to just cut down the drug. And paroxetine is a drug with a very less half-life, so immediate discontinuation of the drugs can cause the same symptoms to occur again. So we all, like psychiatrists as a community, we advise that begin low and go slow.
Yes.
In all psychiatry medications.
Yes, that's what
Just
we also do.
one more addition I would like to have.
Yes, please.
I don't know about all the antipsychotics. I have never experienced in my 8 years of practice rashes with antipsychotics, but there are certain mood stabilizers who have a very high chance and a very lethal chance of having serious dermatological side effects. First one is carbamazepine. Second is valproate, and it also and valproate also causes hair loss. So in bipolar patients, we really find it difficult to continue valproate or convince the patient to continue valproate, especially females, as there is a lot of hair loss with higher doses of valproate. And the most dangerous drug of all is lamotrigine. It has a specific regimen, how to up titrate and how to start the drug, how to increase the doses. So that is the, I think, by far the most difficult drug with dermatological side effects. And the only person I have seen, the only psychiatrist I've seen with efficient usage of lamotrigine is Dr. Deshpande madam,
Sure. Okay.
one of our founders. So it has severe consequences, and it can progress to SGST in any time. I mean,
Okay.
very fatal.
So thank you for your inputs. We'll
No,
move
Chinmay,
on.
you have just
Yeah.
opened 2 devices. That's why the sound is some issues there. So you
No,
please.
I don't have. I
Hello,
don't
Chinmay,
have two
Chinmay.
devices.
Oh, okay. Chinmay.
There's someone else.
Dr. Chinmay has got 2 devices.
Okay, we'll move on. I think.
Was I audible?
So this is my. Now I am. Does anyone have 2 devices?
That is,
I think I
Dr.
think
Chinmay,
I have it.
of the one.
Yeah. I have the 2 devices. I'm sorry for. Yeah.
So.
Okay.
So now let us
So
move on
was
to
there
the
any
next
problem in listening to?
Yeah, the echo will be there.
Yeah, so this is my case of psoriasis, almost similar and parallel to what Dr. Tarun described. A patient, bipolar disease. In addition, he has severe depression, suicidal tendencies. He was put on lithium and he has got this sort of psoriasis. We call it as very severe osteitis type of lesions are there. But psychiatrists were not willing to stop lithium. They said he's controlled only with lithium. So we are managing his psoriasis along with continuing lithium. Sometimes it's very difficult to choose between drug and the disease. So moving on.
So for that, we have to weigh the risk-benefit ratio.
Yeah,
Whether
that's it.
continuing lithium is more in the positive
whether
side of the
lithium
equation
is
or
needed or disease is more
needed, yeah.
dangerous. So here,
Yeah.
of course, psoriasis was more acceptable than losing his life. So we decided to continue with treatment for psoriasis. Actually, he has much improved, though psoriasis is still there. So we always have to outweigh the benefit or risk or whatever. And now what is the prevalence of CIDR? I'm going to skip this question because Dr. Senthil Kumar already gave us the answer. So said it's 5%, 2 to 5%, 8% in some studies. What are the risk factors associated with cutaneous adverse reactions? Have you all noticed any risk factor per se, though textbooks and articles talk of certain risk factors? Anyone can take up this question.
I think Dr. Senthil did mention that female sex or African ethnicity, polypharmacy, and certain HLA types.
Yes.
Now, there are certain HLA types which have been associated with severe reactions with carbamazepine, valproate, even dapsone. We have certain HLA types. So soon we may have individualized or personalized medicine where you can prescribe medicines after doing the HLA typing.
Yes.
So these are the few which come to mind offhand.
Yeah.
And
so the
also there are some collagen vascular disease, especially SLE. Sometimes it may not be some drug reactions. If investigate, there will be NA positivity and also such
NA positivity.
Yeah. So if they have got a NA positivity, they have more chance to get drug reactions.
Yes. So future is for tailored medicine. We don't know how far we'll be able to But this is what books say. High loading dose, as Dr. Chinmay was saying, start slow and slowly increase. HLA subtypes. Do anyone, especially in PGI, sir, do you do HLA typing for carbamazepine or dapsone or anything else? We don't. Anyone does?
No, even we don't do it.
We also
One is that
don't.
we don't prescribe carbamazepine. We are very much afraid of that drug.
Even we don't.
SJS and TN.
There is
And
an
dapsone,
ongoing-
we've seen that dapsone syndrome is not that very common as it has been hyped. So,
Okay.
although out of context for this seminar, but we
But
don't
still,
do.
yes.
Yes.
We are
I think
also not doing here.
Bacavir is the only drug for which HLA typing was done by the internal medicine people, but carbamazepine, I don't think. Sukhdeep, any idea? Do they do it?
We are doing a project on this. It is
Okay,
currently
that's good.
ongoing.
Okay.
We are also not doing, and actually we have conducted one study in our department, and the carbamazepine was the commonest drug producing drug reaction. That's why
Yes.
we are also afraid of giving carbamazepine. But neurology and psychiatry people, they are giving in a very huge chunk, I think.
CBZ, we are
In-
not, in PGI, CBZ,
Sorry.
we are not doing any sort of HLA typing for carbamazepine per se. This is Dr. Sendil here.
Yes.
Okay.
So it's just a project we have probably done that with Sukhdeep and myself and Dr. Handa would be doing it. So it is not started. No, we are not doing any HLA for any other things.
Okay.
In our institute, we use a lot less of carbamazepine, and even if we use, then the controlled release preparation is more. I mean, it has less side effects, less dermatological side effects, because that drug is an auto-inducer of itself. I mean, it reduces its half-life on its own. So we have to shift to controlled release preparation. And also it has interactions with the CYP enzyme system. So valproate or lithium or oxcarbazepine is the new emerging drug which can be used as a mood stabilizer,
Okay.
which has less dermatological side effects.
Oxcarbazepine.
Yeah, oxcarbazepine. It's a congener of carbazepine, but with much less side effects, and not it is not the mainstay of treatment of bipolar, but it can be used as an augmenting agent so that the primary mood stabilizer can be lessened, the dose.
So now, for some few more slides, all these have been beautifully described by Professor Sendil Kumar, sir. I don't want to repeat everything. So I'll just push through. In the meanwhile, I'm taking audience questions. So there is one question which we have got, which says, in general, these are some of the common CADRs or cutaneous adverse reactions which we see to various drugs. In the meanwhile, let us discuss this question. In general, which dermatological drugs like antifungals, anti-acne, anti-psoriatics can be safely prescribed along with antipsychotics? Is there any general fitting like this? What is your opinion? Dr. Latif, Dr. Tarun, or I would like the dermatologists to take it first. Dr. Sukhdeep, any of you? Later, I'll ask Dr. Chinmay.
I don't think you have a general fitting or that you can always prescribe this drug. You have to see what drug the patient is on. Then you can check the interactions of the drug you want to prescribe. And then you can decide whether both these go together or not. So it would be difficult. So as far as possible, try to manage with topicals, I would say, psoriasis or acne. And if you need to give a systemic drug, then you should see which psychotropic drug the patient is on and what do you want to start. Then you can check for interactions, because as there are certain drugs which have common toxicities or which are inducers of the same metabolic enzymes. Then, like if you like psoriasis patient that you showed, I was at a fix when I started seeing for interactions between lithium and methotrexate or cyclosporin or acetate, and all of them have interactions.
Yes.
So what to give to such patients? So that is the problem there, that whether you give low dose, keep monitoring the side effects. So there can't be a general answer to this that you give these drugs, these are very safe. Any drug can have an interaction, except for topicals, I think.
Yes.
So the Dr. Tarun has rightly answered that question, so I'm not going to that.
Yeah. Any other views, Dr. Chinmay? Anything you want to add to this? What I usually do is like,
Sorry,
yeah,
ma'am. I was.
yeah, please.
The question was. I'm
The
sorry.
question was, there was a question asking whether you can give any specific antipsychotic when you are giving dermatology medicines, like antifungals, anti-acne. Anti-acne would be isotretinoin, most probably, or any other antibiotics, etc.
Yes.
So we all came to
Basically,
the conclusion
antipsychotics. Yes, ma'am. Yes, ma'am.
there is nothing safe. We have to go on a case-by-case manner or try topical treatment.
Yes, ma'am. The mainstay of this is start with the lowest dose possible, and then refer to the psychiatrist to
Yes.
up titrate how as per the condition. Secondly, antipsychotics have much less chance of having cutaneous adverse effects than SSRIs or mood stabilizers, certain mood stabilizers. And the second thing. And what was the
That's
last?
all.
I mean,
That's all.
Yeah,
That's all. It's the same, one and all. So,
and
so this,
one more thing, ma'am. The corticosteroids, which are prescribed in prescribed by dermatologists, prednisolone, like in my practice, in my limited practice, I have seen a lot of patients who don't I mean, down titrate Visolone. Visolone has I mean, they get addicted. I don't know what it is, but they don't stop Visolone as they are requested by the dermatologists, and they keep consuming it for years together, and they develop severe psychotic symptoms and or anxiety disorders. I mean, there is no single study to say that it develops certain kind of any certain kind of psychiatric disorders. It can cause various neuropsychiatric side effects, and it is difficult to taper them from the corticosteroids also. So that's one thing that I've observed from the dermatological viewpoint.
so what I do when I want to give any oral antibiotic or antifungal is look up Lexicomp or any such drug interaction database very quickly, and also chat with the psychiatrist if in doubt. So here in the screen, we are seeing alopecia.
Basically,
yeah.
Sorry.
Yeah, continue.
Basically, communication between both the professionals is vital about the patient, even if it is in a general setup or it's in a private setup. Communication between the two professionals is vital. Secondly, you can start with low doses of antipsychotics or antidepressants, but if there is failure to respond with those low doses, then preferably the dermatologist should refer to the psychiatrist.
Yeah.
And then basically it is a consultation line.
Yes.
Yes.
So another question which we have had is, what is the histogenesis of alopecia caused by psychotropics? What I've understood is maybe the person wanted to know which psychotropics cause alopecia and what is the mechanism of action. So anyone?
I have experienced only one psychotropic, that is valproate, sodium valproate,
Sodium valproate.
which causes
You were
significant
telling about it.
hair loss.
Yes. So
Yes.
anyone
Other
else?
than that, I don't think any other psychotropic causes hair loss.
Dr. Sukhdeep, any input?
Regarding lithium, it has been proposed that that causes thyroid abnormalities and that can further affect the
Yes.
hair cycle leading to
Yes.
alopecia.
Yeah.
As a matter of fact, there are numerous mechanisms which have been proposed for
Yeah.
alopecia due to psychotropic drugs. Different psychotropic drugs act at different levels. Some may interfere with the hair growth cycle, cause telogen effluvium. Then some may kind of cause alopecia areata because of the immunogenic mechanisms. Then, as Dr. Sukhdeep said, hypothyroidism. Otherwise, even certain medicines can cause other hormonal abnormalities as well,
Yeah.
like androgens or less of female hormones. So all those can predispose a patient. Then,
Yes. Yes.
then the stress these patients are, that itself can predispose to telogen effluvium, I think.
Yes.
I am not very sure of the exact histogenesis or the pathogenesis, but various mechanisms have been proposed
Yes.
for different drugs.
Actually, it
And
is
in
said
addition
that
to that,
valproate even chelates with zinc and selenium, leading to alopecia. Yes, Dr. Latif?
in addition to that, the psychiatric disease itself may produce telogen
Yeah,
effluvium.
very true.
That also
Any
will add
kind
to
of
the
stress.
hair loss.
Yeah.
Yes.
Any kind of stress,
And yes,
stress reaction in the mind can cause hair loss. That is also true.
telogen effluvium.
Yes. Prolonged stress, basically, like for months, years
Prolonged
together.
stress, chronic telogen
Students,
effluvium.
for example, 2 or 3 months and after the COVID period, there
Yes.
see
There are various psychogenic
many
causes for
cases of
alopecia, no?
all these induced.
Yeah, areata, trichotillomania, so many come to mind. So another question when I'm seeing this slide was that somebody asked about AGEP. Which are the drugs which cause AGEP? One is clozapine, which I mentioned here. Anything else? Has anyone seen AGEP with AGEP is acute generalized exanthematous pustulosis. Has anyone else seen any other cases of AGEP other than clozapine? I have not come across AGEP with clozapine also, only in literature.
We have also not come across any
Actually, we are seeing
such
AGP.
diagnosis by dermatologists.
Other
Sorry.
drugs, AGP is very, very common, but antipsychotics, we didn't come across much.
I've also never come across.
But these antibiotics and all, especially penicillin, azithromycin, such group of drugs, that's very common to use AGP. But antipsychotics, we didn't see much cases.
Not much. So only thing I saw was clozapine in literature. And drugs also. Any drugs
that is also rare,
just
madam.
Yeah.
That
But
is
we
also very rare, madam.
Yeah,
Clozapine.
very rare.
If you start very low and up titrate very slowly, it doesn't
Problem
occur.
is that
If you start with
these
high doses,
type B reactions, you don't need a higher quantity of drugs. Even with very low dose, you can get. So sometimes we can get even with very low dose. So drugs, we had a very good case presentation by Dr. Sukhdeep. So if you can take up the question, if you know of any other drugs.
Other drugs which can commonly cause dress apart, they include clozapine, then even olanzapine, ziprasidone also. And apart from that, the anticonvulsants are the mainly culprits, like phenytoin, carbamazepine, lamotrigine.
Yeah,
and
for drugs, there are many other culprits. And in literature, it was said that lamotrigine can cause severe hepatitis along with drugs. Whenever it is drugs caused by lamotrigine, hepatitis is a very major component. So it seems lamotrigine is a very, very scary drug.
dangerous.
As told by
Yes.
you, Dr. Chinmay. So,
Ma'am, apart from lamotrigine, the second and third are valproate and carbamazepine. I mean, I think carbamazepine and then valproate, because
Carbamazepine,
they
we all use the villain, but
is
lamotrigine
the
is
villain.
upcoming villain. But we all don't use it. Like, we don't use it much.
Yeah.
I think neurologists use it.
Even ma'am, sodium valproate, we have to check the liver function test and
Yeah.
liver enzymes every monthly in the first 6 months, then every 3 months in the next 6 months, and then yearly, because it can, I mean, it causes damage to the liver, definitely.
Yes.
And we also have to assess for a WBC count, because it causes pancytopenia also.
Pancytopenia,
So,
agranulocytosis.
or granulocytosis. These are all life-threatening conditions.
Yes.
So, but they are rare. They are rare side effects. But if they happen, then the patient.
So be vigilant and educate the patient, and patient parties the baseline. So
yes, ma'am.
we were discussing already about these serious life-threatening reactions, or what we fondly call as scars. Vasculitis, has anyone encountered? I have not yet seen a case of vasculitis yet. But these are the drugs which are supposed to cause vasculitis among the psychotropics. If not, we will move ahead.
Well, I have seen 1 or 2 cases of vasculitis cases, especially this mainly due to this carbamazepine such group of drugs.
Okay.
They are producing vasculitic lesions. So that may mimic our usual vasculitis, but see, if you find out is after the starting treatment with these drugs, these are occurring, and no other causes that has to be excluded before labeling it as due to the drug. But in few cases we have seen all other investigations were within normal limit, and after stopping the drug, there was a good improvement immediately after stopping the drug.
These are a couple of articles. So I'm not going into this debate. Do dermatologists need to prescribe psychotropic, or is it better left to psychiatrists? This is for another day. So these are the psychodermatological conditions. It's a simple classification just to refresh our memory. Psychophysiological, psychiatric disorders with dermatological symptoms, dermatological diseases with psychiatric symptoms, and miscellaneous group. So I'm not going to discuss this because we all know by now. We have antipsychotics, anxiolytics, antidepressants, or mood stabilizers, and of course, a miscellaneous group. So now I want to know, to the dermatologists in the panel, which are the common psychotropics you use in your practice. I'll start with Dr. Tarun Narang, because I think Dr. Latif is a complementary psychiatrist also. So Dr. Tarun.
We generally, as you mentioned, we also have a very good liaison with our psychiatry department, and we tend to refer our patients to them. But there are times when the patient is not willing to go to the psychiatrists. Then at times we do prescribe escitalopram low dose, or we even have to start olanzapine or risperidone in a few patients who have delusions of parasitosis, because they are not amenable to suggestions and they won't go to a psychiatrist. They have that fixed idea that it is a cutaneous disease and it has to be managed by a dermatologist. So these are the few instances where we give. Otherwise, we have some patients with psoriasis who have very bad depression. There again, my go-to drug is escitalopram, which is a safe drug, and I give. But eventually, my aim is to kind of involve our psychiatry friends along with that, and eventually the follow-up should be like with both of us, like both psychiatry and dermatology. But olanzapine, I do use it in delusions of parasitosis, and this escitalopram in depression, or even trichotillomania sometimes, and N-acetylcysteine is something which which we started using in patients with trichotillomania. Though some patients improve, others don't. Skin picking disorders, again, there also we prescribe N-acetylcysteine or escitalopram, sertraline sometimes. Then there are patients with psychogenic bronchitis who, again, our first aim is to send them to psychiatry so that a proper evaluation, but we do fill up our screening questionnaires, and after discussing it with our psychiatry colleagues, we start them as well on low dose SSRIs. That's
Ma'am, apart from all these, we also commonly use two commonly used tricyclic antidepressants like doxepin and amitriptyline. They are also commonly used in cases of intractable pruritus. And doxepin, as we know, it has antihistaminic effects as well, and amitriptyline is also commonly used. And apart from that, other miscellaneous drugs like gabapentin, pregabalin, they can also be used in cases of neuralgia and neuropathic pain.
Dr. Latif, anything else?
Actually, when my psychodermatology clinic, I usually use these common drugs. One is mainly the antipsychotic risperidone because delusion, parasitus and all. I will start in a small dose, 1 or 2 milligram, that's all. But if you want a very high dose, usually I will refer to the psychiatrist. Then aripiprazole, that is with a lesser side effect. So that is a very still more safer drug. Then mainly this antidepressant, SSRI is very commonly escitalopram, and also this sertraline, because we have to consider this. One is the sleep of the patient, and the another thing is the pruritus. So if the patient has got very severe pruritus and lack of sleep, I usually prefer mirtazapine. But if the patient has got sleep problem, but with the depressive symptoms, but there are not much pruritus, usually I will put him on sertraline. But if there are no pruritus issue and sleep issue, but features of depression, usually I start on escitalopram.
So
other thing, pregabalin, gabapentin, these are I will use, and also some cases benzodiazepines for a shorter duration, and also some sleep.
Please continue.
Pardon? Sleep inducers also.
We have few more questions.
Yeah.
Yeah, please continue. Sorry, please continue.
So these are the usual molecules I'm using in my clinical practice, and also amitriptyline, because especially this cutaneous dysesthesia, burning mouth or burning genitalia, such things, amitriptyline is a very good molecule. So these are the usual drugs that is, we don't want many drugs, only few molecules are needed in our psychodermatology practice, unless in like the pure psychiatric practice. And if the patient has got very severe depression with suicidal ideation and with the psychotic symptoms, with the lack of insight, such patients, dermatologists can never manage, and better to refer to a psychiatrist.
Yes. So now to Dr. Chinmay, which drug would you recommend that dermatologists use? That drugs which have least incidence of adverse reactions?
Yes, ma'am. For the dermatologists, you can assess the patient's conditions. Basically, there are four main main psychodermatology conditions for which the patient comes to a dermatologist. First is delusion of parasitosis, that is the tactile hallucination or the belief or conviction that they have insects underneath their skin or on their head, and they are continuously preoccupied with the same thing. Then there comes OCD, continuous hand washing, resulting in washerwoman's hands or a washerman's hands, if I remember correctly. And third is trichotillomania, like pulling of the hair. That is a part of obsessive compulsive spectrum of disorders. Earlier, it was not a part of OCD, but now in DSM-5, they have they have put together a group of conditions which have similar traits like OCD. So trichotillomania, hoarding disorder, or body dysmorphic disorder, continuously checking the parts of the body to have symmetry or the color or skin color, preoccupation with that.
Yeah.
So that has also come under OC spectrum of illnesses.
Yes.
And the third is, and the fourth thing is anxiety disorders, which can cause like fidgeting of the hands, which can lead to skin excoriation and repeated like neurotic excoriation, we call them. So these are the four diagnoses which commonly warrant, I mean, for which they come to the dermatology clinic. So if you can assess and find out which category the patient fits in, so then you can start with some basic psychotropic drugs. Like if the patient has delusion of parasitosis, so you can assess for the delusion, like if it's a fixed firm false belief contrary to the evidence given, and not keeping in with the social cultural background.
Okay.
So if it is delusional parasitosis or tactile hallucinations, like he's feeling something pinching his skin or pinching his brain, or and he believes 100% he believes that there are insects, definitely there are insects underneath my skin or in my blood vessels. Yeah. So then that is a delusion. The conviction should be there.
Yeah.
मतलब कि हो सकता है, पता नहीं, that is not a delusion. I know there are there are insects under my skin and they are in my blood vessels. So you can, the most advocated drug is pimoside, but pimoside causes a lot of side effects. It is a first generation antipsychotic.
Yeah.
Now with the advent of newer generation of antipsychotics, like Sir said, risperidone, olanzapine.
Even aripiprazole can be used.
Aripiprazole is a maintenance drug. It is a partial agonist, so it works very late. It is used in the maintenance phase. For acute symptoms, like Sir said, risperidone and
Pimoside.
No pimoside. I currently have a patient since last 3 years who was on pimoside for 10 years, and he developed severe extrapyramidal symptoms, rigidity, and so then I had to shift him to trifluperazine, quetiapine combination, and then fortunately all his movements got reduced. He was on pimoside. He's still following up with me. So pimoside is not recommended by psychiatrists at all. It causes severe muscle spasms and rigidity, and so you can start with basic drugs like risperidone, olanzapine in low doses, like 2.5 to 5 milligram of 2.5 to 5 milligram of olanzapine.
Okay.
And you can tailor it to the person, tailor it to the side effect of the drugs, because olanzapine causes weight gain and increased appetite. So if it's a thin built person, woman, female, or male, young, so you can start olanzapine. So it will help increase their appetite and their weight, and it also causes sedation. But if sleep or appetite is not a problem, then you can use risperidone, 1 or 2 milligram.
Okay, so we have many more questions here. I'm going to take up audience questions now. I'm going to stop our questions here. So there are few questions on dress. How often viral reactivation is responsible in dress? Dr. Sukhdeep or any other dermatologist, can you take it up? Because I am not very sure how often whether we can give some percentage as such.
And regarding viral reactivation, we get all the serologies done, and if it is present, only then we treat the viral reactivation. Like we can give valganciclovir in that case if serology is present.
Okay.
How commonly do you see that, Sukhdeep? How commonly do you see viral reactivation in a case of dress? You've done your thesis on dress, and you are also actively involved in dress.
It is not commonly seen. Like in out of 10 patients, in my thesis, out of 100 patients, I saw it only in around 3 or 4 patients.
Okay.
3 or 4.
We don't even routinely do viral reactivation as part of registrar criteria. It is only mentioned as per the Japanese criteria.
Okay. Another question in dress is, what to do if organ involvement is worse?
In that case, we have to start steroids as the first line, and we can give them either pulse steroids or oral steroids. And if the patient is not responding, we should rapidly switch to either IVIG or cyclosporine can be given.
And one thing which we have seen in dress is that it can sort of recur. So long-term steroids perhaps.
The slow tapering of steroids should be executed. Like steroids should be tapered every 2 weekly, and we should also not rapidly taper them.
Yeah.
The recurrence can also occur due to other drugs, like if amoxicillin is used, for example, in case of dress due to phenytoin, that can also lead to recurrence because of like hypersensitivity, generalized hyperreactivity in the patient.
Yeah, related drugs or other drugs. Another question which we have got is tricyclic antidepressants in post-herpetic neuralgia. Is it safe?
Actually, post-herpetic neuralgia, there are 2 types of pain. One is a lancinating pain, the other one is a dull aching pain. In this lancinating pain, this carbamazepine or pregabalin is concerned, the natural normal side effects will be there, but we should be careful. But 10 milligram and all usually will well tolerate. There won't be much side effects, especially as usual in all other conditions.
Anyone else? Or we'll move on to the next question. Somebody wants to know whether hair loss warrants any stopping. Obviously, we continue psychotropics is what I feel, unless the patient is very.
Yeah, just yesterday I saw a patient on valproate, who is my chronic patient, I mean, since 3 years. And he had a hair loss. He had hair loss since the last 6 months. But you have to weigh the risk and benefit ratio.
Yeah.
I mean, I tried decreasing valproate to a minimum dose of 250. Sorry.
The risk benefit ratio has to be calculated. Alopecia is not a major issue, even though cosmetic issues are there, but the psychiatric
that has to be conveyed to the relatives and the patients both.
And give that treatment for alopecia. That's the one thing.
Yeah. Just yesterday, I gave dermat reference for hair loss, or they can have PRP or what, I don't know, other techniques for the hair growth. But we can't stop valproate because I had tried stopping valproate, but then his symptoms got worsened. Then I had to increase the dose again to the original levels. So
one problem which I faced is patients ask, does this drug cause hair loss? What to tell? We are supposed to tell them, no? To one patient,
Uh,
I said, this may cause, then it seems my psychiatric colleague told me that patient immediately stopped the medication without telling.
yes, yes,
So now it's
yes.
a ethical
If the
dilemma.
sorry,
Yeah, please continue. Want to know how to
ma'am,
go about this.
yes. So what I do usually, or seniors do, I mean, I've learned from my seniors that if the patient has no insight regarding his illness or partial insight regarding his illness, then we need not tell the patient.
Okay.
That is the foremost thing, that whether he has the capacity to assess the situation. If he has, then we can tell him. If he doesn't have, then we can tell the relatives that this will cause hair loss, but you will not have to tell him that this drug is causing hair loss. We can say that due to stress or due to your psychological condition.
The question.
Yeah, circumvent the question. Exactly.
So any other opinion or anything else? Or next question. Somebody wants to know whether clonotril has side effects. If so, which are the side effects of clonotril?
Every drug has side effects. Even the paracetamol that you take has side effects.
Yes.
So every medicine you take has some or the other side effects, but clonotril is considered one of the more safer benzodiazepines than alprazolam or other short-acting drugs, because clonazepam is an intermediate-acting drug, so it has less propensity for addiction or dependence than Restil and these nitrazepam and all those other drugs. So I would say that benzodiazepines you should avoid, or just give short term 7 to 8 days or 2 weeks benzodiazepine, and that too intermediate or long acting. So clonazepam is the ideal choice for anxiety related issues till our SSRIs and our medicines take time to act.
What about
that is 2
buspirone?
weeks.
I've seen some people starting buspirone also.
Buspirone is effective against anxiety, but that too requires 7 to 10 days to have some effect. I mean, the effect starts from day one itself, but that is just some tiny steps.
Okay.
For having at least 40 to 50% improvement. We have to wait for 1.5 to 2 weeks at least.
Okay.
That we have to extend to the patient, that it is not like cough or cold medicine that you will take the medicine and tomorrow 2 days after you will feel better. So we have to counsel the patient about that also. And if needed, we have to increase the dose also. We are starting with a very low dose.
Yes.
That also we have to inform the patient.
Buspirone has less chance for dependence, no?
Dependence.
Yes, sir. Yes, sir. Definitely. But during the first 2 to 3 weeks, we can use benzodiazepines in SOS situations.
Yes.
Like if a person is having panic attacks, or if a person is having repeated thoughts or headache, like pulling sensation of the head, or pushing like a band-like headache, which is indicative of anxiety, then we can give it in the first 2 weeks. Just we have to set the limit for them, that not more than two tablets per day. Like we usually prescribe tablet clonazepam 0.25 milligram in emergency situations, so that it doesn't cause somnolence.
Another question we've got is weight gain with mirtazapine. Of course, it's there. So what are the other side
It occurs in
effects?
only 1/3 of the patients. Weight gain
1/3.
with mirtazapine occurs in 1/3 of the patient, but with olanzapine it is occurs in all patients.
Okay. Is there any way to find out who will develop weight gain? No. What are the other side effects and situations where we avoid mirtazapine?
Mirtazapine should be avoided in any hemodynamic condition like hypertension, because it is a alpha 2 agonist. It causes vasodilation. It is a noradrenaline and serotonin NASSA, NASA. So noradrenaline and I don't exactly remember the full form right now. Agonist. So noradrenaline agonist is causes vasodilation, and it can lead to dizziness and loss of balance. So hypertensive patients or patients with cardiac illness should avoid mirtazapine.
Old age, is it safe?
Old age, if there are no comorbidities, it is safe, but it acts on the autonomous nervous system. So it's better to give
another question is risperidone.
Olanzapine.
Okay, olanzapine.
Yeah, olanzapine has some mood stabilizer effects also. The pines, clozapine, olanzapine, other pines which are there, they have mood effects also. They stabilize the mood also. So you can give olanzapine as in old patient.
Mirtazapine especially is better to avoid in obese individuals, and also with metabolic syndrome, hypertension, diabetes mellitus.
Yes.
Such condition, it is better to avoid mirtazapine.
Another question which we got is risperidone and seborrheic dermatitis. I don't know what they meant, but risperidone causes seborrheic dermatitis. We can treat seborrheic dermatitis, whether we need to stop or what else, I'm not sure.
In my knowledge, risperidone does not have any dermatitis, dermatological reactions. And even if they are, they're not significant.
Study recently, our psychiatry colleagues, we evaluated about 100 patients who were on antipsychotics, and risperidone was the commonest, and seborrheic dermatitis was ill. But it is not a reason to stop the drug. Seborrheic dermatitis is something which is easily manageable.
Which is treatable.
Seborrheic dermatitis as well as melasma. Both these were quite common in patients who were on risperidone. Not very serious side effects though. The patient can continue on treatment. These are easily manageable.
Yes. The antipsychotic is more important than the dermatological side effect, but it is difficult to convince the patient.
That's right. We have 2 more questions and a lot more slides, but I think there is no time. I'll finish off with the audience questions. So now we have a question which asks role of deep brain stimulation as a substitute for prescribing psychotropics. I don't think the dermatologists will have an answer. So no.
Absolutely not. Deep brain stimulation
is an absolute no. Yeah, please continue.
Absolute capital no, NO. Deep brain stimulation has a lot more side effects than our psychotropic medications. Psychotropic medications are much more safer than any other branch of medications. So, answer to that question is
what is deep brain stimulation?
Deep brain stimulation is you have to do a craniotomy, and then you have to insert the needle in the brain. Yeah, it's an invasive procedure. Then at that exact point, it is usually used for OCD. So at the exact point of the caudate nucleus, you have to stimulate the brain.
Yeah.
And it is an invasive operative procedure, like neurosurgeons.
Transcranial magnetic wave stimulation or something like that. That is also
TDCS we can do. We have TDCS.
That is safe, I think.
That is safe. That is non-invasive. You just have to place the electrodes on where you want to focus. It is usually used for somatoform disorders or chronic headaches.
Yes, because
And
Dr. Subhan has been using it for quite some time, and he wanted me to try it in few of our patients with post-herpetic neuralgia or prurigo nodularis also. So that is why I thought I would ask you.
it even acts as a placebo. So even if the
Yes.
patient, even if you don't use the proper dose of the current, the patient, I've seen that patients improve.
That some
Majority of
active
them.
intervention is given to the patient. They'll feel better.
Yeah. Just like when patients feel better after a saline infusion
Yes.
of DNS or NS.
Does risperidone trigger Parkinsonism?
Yes.
Yes.
Yes. Because Parkinsonism was the most common side effect of the typical antipsychotics,
Extrapyramidal.
like doxepin or haloperidol or pimozide. Like they are typical of the first generation of antipsychotics. But risperidone is such a drug that after 6 to 8 milligram, it acts as a typical antipsychotic. Even if it is a second generation antipsychotic, if we increase the dose to more than 6 to 8 milligram, maximum is 8 milligram, based on 4 we give, 4 plus 2 in the morning and the evening. That is the maximum dose we psychiatrists give. But there are psychiatrists who give more than 8 milligram also. But after 8 milligram, it starts to act like a typical antipsychotic, like haloperidol, Serenus. So it has a high chances of extrapyramidal symptoms, especially Parkinsonism, like rigidity or mask-like faces or a slow shuffling gait, slowness of movements. And maximum dose prescribed as per textbooks is 16 milligrams. 16. But no, I haven't seen anybody go more than 10 milligram in my practice or even the medical college.
Urinary retention in an elderly male. Perhaps they want to know which drugs to avoid and which can be prescribed.
Anticholinergic drugs you should avoid
So
for urinary retention. Yeah, first generation you should avoid.
Antipsychotics to be avoided. All newer drugs are relatively safe.
Newer drugs are very safe.
So anyone in the panel has encountered any other ADR other
yes,
than cutaneous?
And this tricyclic antidepressants also, we should be very cautious in elderly because they can also produce anticholinergic side effects.
Dr. Latif, do you use nortriptyline instead of amitriptyline?
No, I usually use amitriptyline
only.
No.
Nortriptyline is a congener. I mean, it's a metabolite of amitriptyline. So it requires more dose than the amitriptyline itself. So the
side effect profile better?
No, if you require more doses, then the side effects will be higher. No?
Okay. Anyone else? Anything to contribute?
There are primary amines and then there are secondary amines. So primary amine is amitriptyline and other imipramine and all those.
Make this my last slide because we have many more slides and not enough time. So we'll just discuss upon this and end the panel. I think we have exceeded time. So I want all the panelists to tell me something about...
Since many dermatologists are there in the group, I think it is better to familiarize few molecules that will be useful in routine practice.
Yeah.
We should study the dosage, the side effect, all things related to that drug. Especially few SSRIs So that's very commonly prescribed drug, and also the tricyclic antidepressant like amitriptyline. So
Yes.
SRI mainly, and also mirtazapine, that is a very good molecule as far as this pruritus is concerned, especially prurigo and all. Our usual antihistamines will not work. In such condition, if you combine mirtazapine and antihistamine like cetirizine, that will produce dramatic relief, especially very severe with lack of sleep and all. You will get very good response by 1 or 2 weeks. Sometimes it will be very wandering response. So I think all the dermatologists, it is better to familiarize few molecules, but they should know the action, the side effect, everything regarding that molecule. Then that will be very useful. Since this type of discussion, we can't refer all the patients to a psychiatrist. And another thing, in psychodermatology, the dose of the drug is not as we are prescribing in psychiatric practice. We need a low dose that will give very good result. And once the skin lesions are improving, the psychiatric comorbidity will respond very quickly, unlike usual psychiatric problem. So that's why dermatologists also should be equipped with some basic molecules that will be very useful in their clinical practice.
So
Any
I have
other?
just
Yeah.
last 2 points I just want to.
Yeah. Yes, please.
So like sir said, some few molecules that dermatologists should be familiar about. So I have an article here which says that escitalopram and sertraline are the most commonly used drugs by the dermatologist. They are usually well tolerated and effective in multiple psychocutaneous disorders. So escitalopram 5 or 10 milligram or sertraline 25-50 milligram, that is enough. And second thing is, as patients have a lot of stigma about going to psychiatrists, you people as dermatologists, you can convince a patient that this requires some psychological attention, and so that they will have less stigma coming to the psychiatry OPD. You can prime them about this can be a mind condition.
Our psychodermatology setup, which was started by Shrutakirti Shenoy madam, that is one of the best liaison setups. That stigma totally goes off.
Exactly, ma'am. And I just have one question. If a person on any psychotropic medication develops rash, then which is the best antihistaminic and dose to give him? Atarax 10 milligram, 25 milligram. What to give him till he consults the dermatologist?
Atarax can cause sedation. No, sometimes it interacts with your psychiatry medications. Like,
that's okay, ma'am.
Not a problem. 25 is better than 10 always. But in very old people, we start with 10. Because one lady whom I started with 25 mg Atarax, she was 60. It seems she slept off and she couldn't be woken up. She had to be admitted for 1 day. Like that much was the sedation. So
yeah, we'll start. We have
I'm
the
we can titrate up also.
Yes, we have the habit of starting slow. Starting low and go slow. So we always give the lowest dose.
They say even 75 mg. Now sustained release Atarax has come up 50 mg. Where they say sedation is not much. I'm not sure.
But Deshpande, actually, what's the problem is these drug reactions are idiosyncratic. There is no dose dependent. So even if you are starting in small concentration, idiosyncratic reactions can happen. So even though there is a mild rash, that can progress to exfoliated dermatitis. Ideal thing is to stop the drug and give antihistamines or something. And any alternative medication that is not belonging to that chemical group, that is better. That's the basic dictum.
Okay, sir. Thank you, sir. Yes.
Most important is to stop the drug.
Stop the drug, yes.
Antihistamines may
psychiatric drug.
Some types of adverse drug reactions, cutaneous drug reactions. It will help in urticaria or a maculopapular rash, which is itchy. But if you have a TEN or SJS, then antihistamines don't have any role in that. So the most important, or the dictum of management of drug reactions or cutaneous drug reactions, is stop the drug. Then everything can be taken care of. Yes.
Because sometimes even a maculopapular rash can progress upwards. SJST.
Oh, yeah, SJST.
Even dress no sometimes appears like
Yes.
a maculopapular rash. So.
Oh. Okay.
So.
And ma'am, what about people who don't, small children or any persons who don't require psychiatric medication? They are on therapy, but they have got itching, like psychogenic itching. But
Psychogenic itching. Psychogenic itching. Sometimes we send to psychiatrists, or we can start that atypical this pregabalin is supposed to be good, doxepin is supposed to be good, or even these
yes, sir.
second SSRIs are good in psychogenic itch. Mirtazapine works well.
We can't prove whether it is psychogenic or non-psychogenic if the
That's
patient is coming first time for us.
Yeah.
So that times.
Before labeling as psychogenic, we have to rule out all the organic things first. That's
Exactly, sir.
We always do rule out.
Only after ruling out all other organic,
Ruling out. Yeah.
we have to make it psychogenic.
Yes, sir. I was just asking for my grandmother.
Mostly old people
who is 97 years old. She has
old people always
atopic. Sorry.
Old people always use the dry skin. That is the one common cause for the thing. So especially winter season and all, the skin will become more dry, and they will use the hot water. The hot water will again increase the dryness. And also, if they use some soapy substance, soaps, that will add to increase the dryness. That will increase the time. All these things has to be managed, and old people will have to, we can manage them. And still that's persisting, you have to rule out any depression. Because there is one common psychiatric morbidity in old people, they are presenting with generalized pruritus.
Yes. Thank you, sir, for
I think we'll end here. I can see one more question in chat box. Oh, nothing is there. Okay. Thank you all. Thank you, panelists, for making this very easy for me. I was enriched with this. And thank you, organizers, once again. So, hope the audience could have a lively.
Thank you. For very happy to see all of you, especially Tarun in the cold climate. Is still alive.
Thank you, ma'am.
Great, no?
Yes.
Good. Yeah.
Thank you for giving me an opportunity to be a part of the panel.
Yeah.
A young psychiatrist. Thank you for that, sir. Tarun Narang, sir. Abdul Latif, sir. And everyone of the EC committee. Thank you for letting me be a part of this. I am way too much junior than all of you.
No. It's like combined effort. Thank you all.
Yes.
So I think we are done, Dr. Naveen.
Thank you, ma'am. That was quite an immersive discussion, which covered a whole range of topics. And I think it's always a good thing when you have more questions than you can cover, as it highlights the interest in the topic and encourages us to continue the work that we do. To conclude the evening, I now request Dr. Tarun Narang, sir, to kindly present the vote of thanks. Over to you, sir.
Thank you, Dr. Naveen. And I think it is customary for me to present this vote of thanks. But all the work was done by Dr. Abhinita. First of all, I would like to thank Dr. Abhinita and Dr. O.P. Singh. Sir has been very kind enough and is very enthusiastic about organizing these webinars before we can actually organize a physical CME, which we are planning soon. So thank you, sir, and thank you, Dr. Abhinita. And then I would like to thank Dr. Smita Prabhu, ma'am, because she was ill, and despite that, she agreed to moderate the panel. And I couldn't feel there could be anyone better than her to moderate this type of a session. Madam has done extensive work in psychotropics and psychodermatology. And thank you all the panelists. Thank you, Chinmay, for giving this idea during our WhatsApp chats, and I think this will benefit both us as well as the psychiatrists. So Dr. Sendil's lecture was wonderful. He gave you clinical pictures and how to manage. Then Dr. Sukhdeep is, I think, one of the authorities on drug hypersensitivity syndrome in PGI now. He has done so much work. Thank you, Sukhdeep, for a wonderful case presentation. And Latif sir for his words of wisdom, as always. Thank you. And at the end, I think Dr. Rajiv couldn't join, so but thank you for agreeing to join in this webinar, and thank you all the people who attended it and for such an interest. We thought the questions kept coming, and very interesting questions. Some of the questions were very interesting. Thank you very much, and thank you IPCA for helping us in organizing this event. Thank you very much. Thank you and good night. Thank you.
Hope to have a physical seminar soon, sir.
Yeah. We are planning somewhere in February end or March, I think. If
Yes, sir.
Dr. Abhinita is here, she might be able to tell you better. I don't know whether she is
Definitely,
joined or
sir.
not.
Sir, I think ma'am hasn't joined.
Okay. Anyways, thank you all and good night. Thank you.
Yes. Good night, sir. Good night, ma'am. Everyone.
So good night, everyone.